all, so
Sure.
that there are no surprises when we start. That's all.
Yeah.
Ma'am, we are live on YouTube now.
Okay. Good evening, everyone, and welcome to yet another webinar by Nephrocon. Nephrocon was started in October 2023, and we have successfully completed 2 years. We started out as a team of 3 nephrologists, and now we are a team of 5, comprising of Dr. Kirish Kumtekar, Dr. Suhas Monde, Dr. Manan Doshi, Dr. Saurabh Khiste, and myself. And all the 4 gentlemen are from Pune, while I am from Chhatrapati Sambhaji Nagar, previously known as Aurangabad. Since the very beginning of the webinar series, we have been extensively supported by SEMA Call from Acognos Life Sciences. So as we wrap up 2025 and gear up for an exciting 2026, we wanted this session to truly feel special. And since December is the season of celebrations, we thought we'd host a cardiorenal date night featuring 2 intensivists, a cardiologist, and a nephrologist, all in one virtual room. Tonight's format is simple and engaging. We'll have a 20 minutes of focused presentation, followed by a 40-minute discussion with our faculty. We are privileged to have a faculty which needs no introduction. We have our speaker, Dr. Srinivas Samvedam sir, from Hyderabad. He's the president of Indian Society of Critical Care Medicine. We have Dr. Rahul Pandit. He's the Critical Care and Emergency Medical Services Chair at HN Reliance Foundation, Mumbai. Then we have Dr. Rajsekhar Chakravarti, Senior Consultant Nephrologist, Clinical Director and HOD Nephrology and Transplant Services, Yashoda Hospitals, Hyderabad. And Dr. Ajit Bhagwat, Director of Cardiac Cath Lab and Intervention Cardiology, Kamalnayan Bajaj Hospital, Chhatrapati Sambhajinagar. A very warm welcome to all our esteemed faculty and everyone joining us live. To open the discussion, it is my pleasure to invite Dr. Srinivas Samvedam sir to deliver his talk on changing paradigms in the diagnosis and management of cardiorenal syndrome. Over to you, sir.
Thank you. Thank you, team, for inviting me, and it's a privilege to be sharing these screens with Dr. Chakravarti and Dr. Rahul Pandit. It's a privilege for me and an honor. So in the next 20 minutes, I will try to be concise and brief about the changing paradigms in the diagnosis and management of cardiorenal syndrome. I won't talk about the definitions because I assume all of us know what it is, but I would like to draw attention to the magnitude of the problem. At this point of time, we have data about the chronic forms of cardiorenal syndrome, where chronic kidney disease is seen in 15% of adults across the world, maybe a little higher in India, and heart failure is seen in about 2% of adults, with 50% of them having preserved ejection fraction. Now, the overlap of the chronic forms of cardiorenal syndrome is seen in about 1% of adults and about 40 to 50% of heart failure patients. Now, the problem is with the acute forms of the cardiorenal syndrome. We don't yet have absolute figures on how many patients who develop non-cardiac acute kidney injury, either because of sepsis or trauma or a pancreatitis, develop a cardiac issue. We don't have hard figures. So this magnitude of the problem is something we are yet to understand at this point of time. The diagnosis of cardiorenal syndrome is also undergone a sea change after Ronco actually described this constellation of manifestations. We are now looking at cardiorenal syndrome happening in a situation beyond low cardiac output. And that is because of our better understanding of heart failure with preserved ejection fraction. We have also grown beyond this concept of understanding that every raised creatinine is acute kidney injury. It may not be so. So we have to understand that we need to differentiate between a pseudo-acute kidney injury as evidenced by a rise in creatinine, versus true injury by other markers of a volume overload or a biomarker-based therapy or other manifestations or other constellation of presentations. Sorry. To aid us in this, we have novel biomarkers, which I will speak to you briefly. But most importantly, what we need to understand is that
Shivaji, please.
You okay, huh?
Sarji, please.
okay. So to help us in doing this, we need to have an integrated assessment with different tools and different specialties put together. So when you talk about cardiorenal syndrome beyond low cardiac output, we need to understand how you diagnose the cardiorenal syndrome in patients with heart failure with preserved ejection fraction, and we know the common risk factors. So you do the renal assessment by using some biomarkers, the EGFR, looking at the urine sodium and proteinuria and protein creatinine ratio. Maybe we should look at the renal ultrasound and take early nephrology service opinion. In the cardiac assessment, we also need to look at the tricuspid, the right heart, which is an important determinant of the forward flow. And we also need to look at the biomarkers like the proBNP and CA-125, and we look at valvular heart diseases, arrhythmias as an important trigger. So this is where we understand that cardiorenal syndrome can happen beyond the purview of a low cardiac output state. So the biomarkers which I spoke about, we have biomarkers of glomerular function, we have biomarkers of tubular function, and we have cardiac biomarkers, and we have other biomarkers. So we know that urea and creatinine are the established glomerular biomarkers, but albumin and creatinine clearance probably are good supplements for creatinine and urea, especially in the context of excluding pseudo-acute kidney injury. Similarly, the KIM1, NGAL, and FABP are markers of tubular function, but not always available in the for all hospitals across this country. So looking at urinary electrolytes, for example, a urinary potassium, a transtubular potassium gradient, can help you to pick up early tubular injury, especially those related to a nephrotoxin or antibiotic related acute kidney injury. We know about the cardiac biomarkers, and we also need to understand that we need to look at the renal function and the volume overload as when we interpret the natriuretic peptides. Plasma renin activity is something which is an integral part of assessment or integral part of the pathophysiology of vasodilatory shock. And my own student a couple of years ago did a very elegant study on plasma renin activity in septic shock, and he pointed out and he understood that this is the plasma renin activity is an earlier marker of hypoperfusion and systemic oxygen deprivation than a lactate. So it is an emerging marker which we will see more often in the workup of patients with type 5 cardiorenal syndrome. So when we say an integrated assessment, we look at the combination of therapy, you look at the drug history, you look at management of anemia, you look at the vasopressor and inotropic therapy, and you also look at the feasibility of circulatory support. We will look at extracorporeal supports for cardiorenal syndrome towards the end of this talk. We need to look at all these options when you are dealing with a patient with a cardiorenal syndrome. So when we look at beyond the low cardiac output scenario, it's just not the ejection fraction. With the availability of ultrasound and with understanding of the philosophy of venous congestion, we also now understand that volume overload and venous congestion is as important as is an important predictor of renal injury as hypovolemia and intravascular hypotension. Just as we have congestive cardiac failure, we now know that there is congestive renal failure as well. And that is the important paradigm shift in understanding cardiorenal syndrome. while it may happen, while we understand that there is a VEXA score which will help you to understand venous congestion, the importance of measuring intra-abdominal pressure also has to be understood. Because these patients who receive a lot of volume resuscitation and therefore have venous congestion on the VEXA score will also have a degree of intra-abdominal hypertension. And this intra-abdominal hypertension confuses and confounds the abdominal perfusion pressure. Along with the abdominal perfusion pressure, it also confounds the renal diastolic pressure. So when the renal diastolic blood pressure is confounded, you have patients with hypofiltration and activation of the renin-angiotensin-aldosterone axis. So when I spoke about the VEXA score, I don't want to go into the details of the VEXA score because all of you would have been aware of it by now. What I would like to point out is that the VEXA score has a direct correlation with right atrial pressure and the mean pulmonary arterial pressure. That means the non-compliance of both sides of the heart are reflected in the VEXA score. So if your VEXA grade is 2, you are looking at a right atrial pressure of more than 12 and a pulmonary artery pressure of more than 25, which means both chambers of the heart can be represented by a point of care replicable non-invasive tool like the VEXA. And this is not simply to offload the patients. This score will also help you to optimize the function of the right heart and also try to optimize the function of the left heart. And that is where VEXA as a paradigm shift has stepped into the management of cardiorenal syndrome. There are certain paradigms which have come in for the management of the chronic forms of cardiorenal syndrome, and that is the advent of the SGLT2 inhibitors as foundation therapy. Our diuretic strategies have become optimized to the point that we now consider giving diuretic holiday and renal rest to the reset option to the kidneys. You have newer mineralocorticoid receptor antagonists, and there are device-based therapies. But the fact that intensivists, cardiologists, and nephrologists are sitting on this panel today and speaking about cardiorenal syndrome brings into focus the need for integrated multidisciplinary care for these patients for better patient outcomes, for a comprehensive approach for the complex pathophysiological syndrome which cardiorenal syndrome is. So when you look at SGLT2 inhibition, SGLT2 inhibition has beneficial effects both on the kidney as well as on the heart. It has an effect on the glucose and sodium reabsorption. As we will see subsequently, there is something called as sodium avidity. And this sodium avidity is positively acted upon by the SGLT2 inhibitors. So the toxicity of HbA1c, the caloric imbalance, the albuminuria, the GFR decline are all having a favorable influence with the use of SGLT2 inhibitors. Similarly, when you look at the cardiac function, the remodeling of the heart, the arrhythmogenicity of the myocardium, the decreased systolic function, the arterial stiffness, the myocardial oxygen demand, they are all positively influenced by the use of SGLT2 inhibition. So this group of drugs will have a big role to play in the management of patients in the chronic forms of cardiorenal syndrome. But again, here I would like to draw attention to the fact that we do not yet know what is the influence of the acute forms of cardiorenal syndrome in the future genesis of the chronic forms of cardiorenal syndrome. We know that an acute kidney injury in the ICU with or without RRT is a risk factor for CKD. But do we know that an acute form of cardiorenal syndrome is a precursor for a chronic form of cardiorenal syndrome? If we understand that, our focus on SGLT2 inhibition might actually become better, and our thresholds would improve. So it's a bidirectional influence of positive effect of cardiorenal syndrome with the help of the SGLT2 inhibitors. Similarly, with the mineralocorticoid receptor antagonist, the spironolactone, lebrikizumab have a definite beneficial effect, and the non-steroidal finerenone is something which has come into the picture with a shorter half-life and with the mineralocorticoid receptor selectivity and a higher potency when compared to epinephrine. So these group of drugs, along with the SGLT2 inhibitors, probably will become an integral part of management of acute forms of disease, although they are now integral part of managing the chronic forms of the disease. Certain concepts, however, need to be understood for all of us who are managing these patients with any form of cardiorenal syndrome. And that's about diuretic resistance, the sodium avidity, the diuretic holiday, and the option to give a reset or time to the kidney. And of course, we should look at device therapy and the concepts of forward failure and backward failure. When you talk about device therapy, we have to understand the DRI2P2 concept of different therapies available for the cardiorenal syndrome. When you look at diuretic resistance, it's not just the low cardiac output which reduces the renal perfusion. We also need to understand that diuretic resistance is also triggered by venous congestion and also the hypoalbuminemia, which is very common amongst this set of patients. So put together, all these entities will act upon the renin-angiotensin-aldosterone system along with the tubular remodeling and become the cornerstone of the pathogenesis of diuretic resistance. Similarly, sodium avidity, which is the kidney's heightened pathological tendency to retain sodium and water even when the body has excess fluid. Now, when a patient is bloated, you expect hyponatremia, but you find these patients hypernatremic, and your tendency is to give them free water. And this is the reason why we miss the pathogenesis of this sodium avidity. And if you look at this, the weight change baseline in patients who have high renal sodium avidity, they do not tend to lose weight with diuretic therapy. So this is something we need to understand, that a failing kidney sometimes reacts abnormally in retaining sodium and thereby retaining water. And therefore, the positive fluid balance is an integral side effect of this failing kidney. We also have to understand that while managing some of these patients, the concept of diuretic holiday has to be thought of, which is a temporary pause or reduction in the diuretic therapy, especially the chronic forms of the disease, to help the kidneys reset, get rid of the sodium avidity. So what the reset does is to reverse the avidity for sodium, offload the patients, restore responsiveness to diuretics, and therefore will minimize the neurohumor hormonal activation, which is an integral part of the detrimental effects on the heart, which kidney injury can confer. So if you look at the different types of kidney injury, cardiorenal syndrome, if you look at the acute type 1 form of cardiorenal syndrome, the paradigm is now changing to understand the role of oxidative stress and cytokine secretion, and also the concept of renal perfusion pressures. So an understanding of this concept is an important paradigm shift in the understanding of the type 1 cardiorenal syndrome. If you look at the chronic form of the cardiorenal syndrome, where you understand that there is a decreased GFR and RAS activation, the role of electrolyte disturbances, the coagulation imbalances, arrhythmias, and ischemic insult has increased to the point of the concept of thromboinflammation, which is an integral part of sepsis management. Sepsis pathogenesis is also a part of the chronic cardiorenal syndrome pathogenesis. So we need to understand that as well. When you look at the acute renocardiac complications, we need to understand that the effect of your renal replacement therapy on the right heart function, on your tricuspid annular plane systolic excursion, on your CVP, your intra-abdominal pressure, will have a bearing on what effect this kidney injury has on heart failure. Similarly, in type 4, we need to understand the role of hemoglobin, the role of erythropoietin resistance, the decreased endothelial proliferation, and of course, the sympathetic nervous system activation, because this will influence what therapy you are going to offer to a patient with cardiorenal syndrome. So this probably brings into focus the need for a tailored therapy. You need to have appropriate hemodynamic monitoring. You need to have appropriate RAS inhibition, MRAs, and SGLT2 inhibition. Judicious but appropriate and timely use of diuretics, to the point use of inotropes. All this will help to achieve that harmony between the heart and kidney to reverse this complex physiology of cardiorenal syndrome. So that brings us to the DRI2P2 concept of mechanical therapy for patients with cardiorenal syndrome. So the D stands for dilators, vasodilators, inodilators, and decongestive therapies with either medicines or with machines. Renal replacement, different forms, including continuous ultrafiltration techniques, the use of inotropes, the management of interstitial fluid, the concept of the pullers and pushers. This is a mechanical concept. I will explain to you what they are, and selective drug delivery. In here, we need to understand the role of therapeutic drug monitoring. The different forms of RRTs, whether it is in intermittent hemodialysis, which is SLED, or CRRT, will have a bearing on protein binding, will have a bearing on the circulating concentrations of different drugs, antibiotics, plus diuretics, and we need to understand this concept as well. When I mention the word pushers, the pushers are intended to be temporarily implanted in the descending aorta above the renal artery. You can see this is where it is deployed, which increases the flow towards the renal arteries to improve the renal perfusion pressure, and probably will also act like an IABP to decrease the left ventricular afterload. Three different mechanisms are available called the return pump, the aortics, and the second heart assist. They are showing encouraging results in preliminary studies. These are the pushers. That means they push the blood towards the renal perfusion. The pullers, which will suck the blood into the heart, it will reduce the cardiac volume overload and filling pressures at the superior or inferior vena cava, and will decrease the venous congestion at the abdominal cavity. So this is like a pulmonary artery catheter which is floated and which will propel the blood into the heart and pump it forward. And this is called the precardia device. This will help you to offload your intra-abdominal pressure, thereby improving your renal perfusion pressure. So different drugs have been discussed, like the RAS inhibition, the ARNIs, the SGLT2 inhibitors, the mineralocorticoid receptor antagonists, and the GLP-1 receptor antagonists. They have varied effects on the renal hemodynamics, especially on the GFR. Some of them have bigger effect, some of them have minimal effect, some of them have effect both on blood glucose and blood pressure, while some of them have only action on blood glucose reduction. But what they all achieve is reducing the incidence of major acute cardiac events in patients with kidney injury, and also improve the renal outcomes among patients with cardiac injury. So these are the 5 groups of drugs which we actively need to consider in the pharmacological prescription among patients with both acute and chronic forms of cardiorenal syndrome. So this is the role of the ARNIs, which will act upon the angiotensin-renin activation system, as well as the natriuretic peptide mechanism, to have a preferential effect on natriuresis, cardiac remodeling, and glomerular filtration. In the end, we cannot but ignore the role of imaging in assessment of patients with the cardiorenal syndrome. So when you have the type 1 cardiorenal syndrome, you can assess the structure of the kidney by using ultrasound, CT, and MR. You could look at the function by using nuclear medicine techniques. You could use the tissue characterization, and you could use the function by using nuclear medicine techniques. So the use of ultrasound, CT, MR, and nuclear medicine as an integrated approach has a big role to play in precision medicine and in personalizing your therapy for patients with cardiorenal syndrome. So I will just briefly go through your manifestations of cardiorenal syndrome. You look at worsening renal function in the acute forms. You give a diuretic challenge, look at the diuretic response, and then look at renal replacement therapy. The chronic forms, early RRT, appropriate therapy for standard indications. The acute forms of the type 2, you should adjust for the drug, avoid nephrotoxic drugs, do adjusted dose drugs according to the modality of renal replacement therapy, use the lowest dose of loop diuretic possible, use up-titrate your neurohormonal blockers, and consider SGLT2 inhibitors if the patient is a diabetic type 2. In type 4, we know that we need to look at the albuminuria, hypertension, but we also need to look at acidosis, hyperkalemia, the fluid overload, the anemia, and the dyslipidemia as triggers and precipitants of worsening in patients with type 4 cardiorenal syndrome. So I would summarize this entire discussion by saying that heart failure and acute kidney injury are multi-system syndromes. When I just started my career in India in 2006, I heard Dr. Rajshekhar Chakravarti always say that kidney injury is a multi-organ disease. It's not a single disease, and there is organ crosstalk. I've heard him say so many times. And over the years, I've realized that what he was saying 25 years ago is actually true. And multi organ involvement is the norm in both forms of this disease. So we need to understand the key concepts which I have alluded to during the earlier part of my presentation. And pathophysiology of each of these conditions should guide therapy, and individualized prescriptions are needed for better outcomes among these patients. And to help us doing that, sonography is a useful tool, and we should all learn equip ourselves with this essential technique. Multiple devices are likely to be available, so we should know which device should be used when and for what kind of patients. For this, again, as I've said before and reiterated multiple times, multidisciplinary care is essential for successful outcomes among patients with cardiorenal syndrome. Thank you very much for this opportunity.
Thank
I
you.
hope I have been on time.
Thank you, sir. Thank you so much. That was an excellent talk. It's always a pleasure listening to you. Now I request Purva to just start the panel discussion, and we are eager to listen to your insights and enrich our knowledge. Purva, please continue.
Indeed, it was a 360-degree overview of cardiorenal syndrome. And now that we have set the mood for our cardiorenal date night, it's time to begin the most important part of the evening, our panel discussion. Just like every memorable date has a special setting, cardiorenal syndrome has one too. And unfortunately, it's not a candlelight cafe, but a common meeting place for all specialists, and that is the ICU. So, before I begin, I encourage all attendees to post questions in the chat box. If time permits, I will take them up. If not, I request the faculty to please answer them in the chat box itself. So my first question is to Dr. Rahul Pandit, sir. Beginning with an acute event, what is your unit's protocol for initiating dialysis in patients who are post CABG or post PTCA? Any immediate post procedure period? And what clinical triggers do you prioritize in these high risk patients, high risk settings?
Thank you, Dr. Purva. It is indeed a pleasure and honor to be here. So let's go straight to the question. Let's try and answer the question to the best of our ability, because immediate post-procedure and the topic cardiorenal syndrome may not be actually together as a one entity. We may have both the entities present, or we may actually have just one and the other may be not completely there as well. So I think we have to go by simplification of the problem. So if it's a post CABG or a post PTCA patient, you're looking at all the three possibilities. One is the volume the problem. Other one is the blood pressure, which could be the pre-renal filling pressure, which could be a problem. And of course, many a times these patients actually have heart failure with ejection, without ejection fraction, which may be a component which may have not been that optimized beforehand, and which happens quite often, where you may have a lot of volume overload. So when do I start thinking of dialysis in these patients? I think in the simplistic way, I look at whether I need to actually clear the volume, whether I have got adequate filling pressures or not, whether my blood pressure is good or not. And I really don't go and do a VEXA score in these patients immediately post-operatively. I do not actually look at the entire VEXAs, but yes, we do look at the filling pressures. So by doing a cardiac echo, um, sometimes some of these patients may have a pulmonary artery catheter, which is not very common nowadays. Many of the CABGs come without a pulmonary artery catheter as well. If we do have a pulmonary artery catheter, the fluid can be guided reasonably well, and you may have an adequate PA diastolic filling pressures, which you could actually monitor and decide whether you need to dialyze them or not. Acid base forms a very important aspect in these patients if I have to think of dialysis. So my clinical trigger would be if I think that I need to get rid of the volume, or if my acidosis is really bad. These are the only two clinical triggers which I would think in the immediate post-operative or post-PTCA scenario. And I'm sort of trying to quantify that within the first 24 to 36 hours scenario.
So, continuing with that discussion about CABG and cardiac surgery, I'd like to ask Chakravarti sir if there is any evidence or a practical use of remote ischemic preconditioning to prevent AKI after cardiac surgery.
So, thank you for having me here. After listening to Dr. Srinivas Samvedam's, as you said, 360-degree, he has covered almost 25 years of research in few minutes, which is very crisp, and I believe that was a good way to start it off. Coming to the question per se, in my practice, we don't do remote ischemic preconditioning, but there was data which was popular some time ago, but both the randomized trials which were used for remote ischemic preconditioning were a negative trials. So the concept looks like you cause ischemia by compressing your lower limb for 15 minutes or so, and this ischemia patient goes for a cardiac surgery, and post-operatively there is less AKI in those people who were exposed to some remote ischemia like a lower limb ischemia or so. One of the things that probably came out of this understanding is using Dr. Shimas did mention about erythropoietin's resistance or erythropoietin role in cardiorenal syndrome. So when you have a ischemia, you actually have what is known as a HIF, and there was some very early study done on HIF inhibitor, HIF hydroxylase inhibitors. So what happens when HIF is produced in the tissue? It is degraded very fast. But if it continues to stay, or sustained expression of HIF in the tissue probably has a role in preventing AKI. So when you do remote ischemic preconditioning, there is some way of increasing HIF, but people did try to use certain molecules which were HIF hydroxylase, which metabolizes it, inhibitors, so that it can stay longer. I don't think that saw the light of the day, those molecules, but please be aware using erythropoietin in this subset or other ESAs which are not erythropoietin, could be desidustat or any one of those molecules, also could do something similar to the tissue. So I believe this is a area where all of us should spend some more time understanding the concepts and probably have some original work done. So with that, I think there is a role for ischemic preconditioning remote, but then as of now, there is nothing concrete which we can say that this data is supportive of this maneuver. Thank you.
Right. Any comments by the intensivists? What do you all practice this?
I was involved in a pilot study around 10 years or 11 years ago, where I was briefly visiting Australia to do one of my 2, 3 weeks, where this unit was sort of looking at a pilot study. It looks very promising, but unfortunately, the evidence has not sort of come up to a point where we can actually call it as a practice-changing evidence right now. I believe we need a large clinical trial. Um, Definitely better than dopamine, better than giving 1 liter of saline, better than giving bicarbonate in terms of physiologically. But whether it's actually going to make our practice better, I think we need to just wait and see. I've sort of used it in a couple of patients. I've seen it being used in a couple of patients, as I said, but really we need to wait still.
Right. So my next question is to Samvedam sir. Rahul sir has already mentioned that he does not use Vexus immediately post-op. But otherwise, how do you think, how useful is the role of Vexus, POCUS, even biomarkers in clinical practice?
So, uh, I have a little bit of concern about this Vexus scoring, and my concern and worry is that indiscriminate use of Vexus will probably make it unpopular very soon. The reason is you should actually know on what subgroup of patients you are using the Vexus score, right? You get a patient with pancreatitis, for example, or you have a patient with an ovarian hyperstimulation syndrome, for example. They are expected to have a compressed IVC. They will not have an IVC of more than 2 centimeters. which is the beginning point of the vexus. Now you start there and you find an IVC that is less than 2 centimeters, and you don't look at the rest of the venous system. You end up giving more fluids to the patient and causing more harm to these patients. So my protocol or my system in my unit is you do the vexus, but also a priori, before you start doing the vexus, you measure the intra-abdominal pressure. If the intra-abdominal pressure is more than 8, then vexus does not become the tool, or we just don't go by IVC as a starting point. We look at all the other three aspects of the vexus before we say that this is actually volume overload. Point of care ultrasound is a different ball game because it involves assessment of the right heart, it assessment of the lungs, and assessment of even optic nerve sheath diameter, which is a very early manifestation of volume overload. It's not just neurological; it has a role in the assessment of fluid status as well. So when you look at focus, when you have a patient who's received fluids or has a cardiac issue, and I'm thinking of giving more fluids to this patient, and I find a B profile on my ultrasound or my tricuspid, or if I increase the PEEP on my ventilator, the tricuspid annular plane systolic excursion is actually worsening, then I would say that this patient has got a non-compliant right ventricle, and I would focus my therapies on optimizing that aspect. Unfortunately, I am disappointed with the current status of biomarkers because although Marlies Osterman published that series of phenotypes of acute kidney injury where you have creatinine in your Kidigo positive, biomarker negative, Kidigo negative, biomarker positive. It's not as simplistic as it looks. It's a much more complex scenario. So at this point of time, I would probably look at biomarkers as something which is still a research tool or still a hypothesis generating aspect and is still not part of a active decision making algorithm in my ICU.
With this, sir, I just have one small comment. Our focus is now changing from intravascular volume status towards total body water. So, do you think the cumulative fluid balance, which is a very simple tool to assess and calculate, can it be added to this list of tools to assess the volume status in acute cardiovascular syndrome?
So Girish, we let us put it in a very practical and pragmatic way. Patients who are extravascularly volume overloaded are intravascularly volume depleted, right?
Exactly.
Just because somebody has got a B profile on his lung ultrasound and has got a Vexus grading of 6, it doesn't mean that he is intravascularly full. He may be intravascularly volume depleted and interstitially full. So interstitial edema, interstitial management of interstitial fluid is as important an aspect as management of the intravascular volume. So I think an assessment of intravascular volume status by dynamic indices, along with an assessment of the extravascular volume status using some of these tools is very important. And again, here the lung ultrasound is the earliest marker of increased extravascular lung water. You don't need to put electrical impedance or one of those fancy tools to understand. As you track your patient, if your lung ultrasound score is worsening in terms of interstitial pattern, you are looking at an EVLW that is crossing 13 mils per kilogram of ideal body weight.
Right, right. Point taken.
Can I make one more comment on this? Purva, as Srinivas has covered
Yes, yes,
fantastic well.
Yes, sir.
The
Yes, sir.
only one thing which we realized, one of our DNB student is doing a thesis on Vexus right now. And what we have realized is, and there are a number of studies which have sort of shown a similar sort of a result, is that our IVC diameter in the Asian and Indian population is actually normally less than 2 on many occasions, and a full diameter would be around 1.6, 1.7 centimeters. We would call it as a non-collapsing full IVC. So this 2 centimeter and above, which is the first cutoff on Vexus, actually may not be applicable to our population in large. So what Dr. Samvedan said is very important, that you just don't look at IVC and then decide to go forward or not. you actually do all the components of excess. What he said is right, absolutely. And we now realized somebody who has the IVC which is less than 2 may still have changes seen in the hepatic or the portal veins, which then becomes important for us to diagnose the fluids.
Right. So I think the take home for this question would be that we need to correlate clinically and just not rely on numbers and subjective analysis of focus or vexus, and biomarkers are still yet to be explored in our country.
Again, cumulative fluid balance, what Dr. Girish said, is easier done if you have a EMR or electronic health record where it gets documented quite meticulously. Um, Probably because it sort of comes up as a number showing up all the time. If you have to ask somebody to do a cumulative fluid balance, it does become a bit tedious. And you may not get a very accurate assessment of how much cumulatively the patient is positive or negative.
Right, sir.
Right.
Right.
Sir, moving on, although it is the domain of a nephrologist, but when it's done in the ICU, is the intensivist who preliminarily take a call on this decongestive therapy. That so, in case a patient requires renal replacement therapy in ICU in emergencies, especially in the background of cardiorenal syndrome, as an intensivist, which modality do you prefer in your unit while managing the case?
So, Dr.
And
Pura, majority of it is based on the hemodynamics of the patient and how the patient will tolerate it. If it's purely a fluid problem and not somewhere I want to actually do anything more than just removal of fluid, I would just use an ultrafiltration technique. Okay, I would just ultrafiltrate using a CRRT circuit or a sled circuit as well at times, and we might just get liters and liters of fluid out depending on how the patient's hemodynamics are tolerated. If you ask me my modality of choice in a patient who is critically ill, who may require organ support, I think CRRT fits the best bill. Unfortunately, the cost is very, very high. Um, we may be sitting on the tip of the iceberg in some of the hospitals where the cost may not be a problem. And if you look at the sled, it gives you a reasonably good option as opposed to CRRT to actually do a prolonged set. And nowadays we are um, quite cost conscious, all of us, not just we, all of us are quite cost conscious. And we very often do 12 hours, 13 hours to 14 hours of sled as well, just to continue with the dialysis modality so that it actually helps us to do both the functions where we are dialyzing as we are ultrafiltrating and removing some fluid as well. So yes, if you ask me my personal choice, it would be CRRT. If you ask me my most productive choice, it would be SLED. Peritoneal dialysis, unfortunately, no. But for chronic cardiorenal syndrome, you may have a place in it, which would again go back into your domain because majority of these patients may not be with us in the ICU. They would probably be in the wards or at home. So I think there is some role for peritoneal dialysis for chronic cardiorenal syndrome patients where just volume over a period of 24 hours removal becomes an easier modality, can be done by the patient or the patient's attendant, and it becomes easier for them to manage.
right. Just before we go on to the next question, I just want a quick comment by Chakravarti sir on the role of, we are aware of CRRT and SLED, but whether PD has been used in acute CRS cases in the ICU.
So, many of you may be aware, we were part of some data that we originally produced after 2009, and almost 67 patients who had a acute on chronic heart failure. We put them on peritoneal dialysis, and 33 of these patients were 2-year follow-up, and we published it in Indian Journal of Nephrology. So I agree with Dr. Rahul. It has a great role in chronic, but it cannot be discounted in acute. You can use a cycler and use it in the ICU. We had a lady last week in our ICU who was on CRRT for cardiorenal syndrome. We put a catheter and we could wean her off CRRT, shifted to room and then discharge her. So I believe intensivists, nephrologists should have a little more learning of concepts of PD in the ICU. and it is one of the most underutilized modality in our country and the West for whatever reasons. We will not have time to go into those reasons, but it's a great modality for acute and as well as chronic heart failure. And we have some experience, including post-operative cardiac surgery patients in whom we discharge them on PD catheters. Thank you.
Thank you, sir. Thank you, sir.
Right. So recently, in 2022, NEJ published the results of ADWAR trial, wherein they studied around 500 patients with decompensated heart failure and found the combination of loop diuretic and acetazolamide, which was better for decongestion. So, for keeping that trial in mind, my next question is to Ajit Bhagwat sir. What is your experience with the use of acetazolamide for decongestion? And what precautions do you take in CKD or AKI on CKD patients?
You are asking me two different questions, right?
Yes, yes,
First question was about acetazolamide in treatment of heart failure.
right. And the second one being the role of acetazolamide in the background of heart failure with CKD or AKI on CKD.
See, basically, this trial which you are quoting, which was published in NEJM, was in patients with impaired renal function. And actually, it was randomized trial. I think there were 500 patients. They were randomized in two groups. One was with IV loop diuretic alone with placebo, and the other group was IV loop diuretic with acetazolamide. And acetazolamide, as all of us know, it is a carbonic anhydrase inhibitor. And they use single dose of, I think they use a single dose of Dimox, acetazolamide, along with 2 doses of loop diuretic. And at
Yes.
that, and the follow-up was for like 2 to 3 days, because the endpoints were studied pretty quickly. And what they studied was how quickly the patient got decongested, how quickly the patient got relief from symptoms. And the interesting finding was acetazolamide was better than placebo in terms of its magnitude of effect, in terms of number of patients which got relief. Number two, rapidity of relief was pretty quick. Number three, the hospital stay was reduced. And the incidence of rise in creatinine was little more with acetazolamide, but incidence of kidney injury was not different in two groups. So it is important to note that injectable acetazolamide is useful in certain group of patients. Number one, those who have got very significant volume overload, very significant. They're bloated patients. Number two, patients whose renal bicarb is more than 25. The alkalotic patients. And number three, patients who had a GFR of more than 20-25. GFR less than 20-25, they don't respond as much. So basically, personally, I don't have much experience with IV acetazolamide, because we still use IV loop diuretics, and if they don't work, we add metolazone, which generally works fine in most of our patients. I have not come to a point where I was pushed to think about a diuretic, or Dimox or acetazolamide beyond these two, the combination of these two which I mentioned. So personally, I cannot quote my own experience, but this is what the trial showed. And I think one should definitely try this drug in patients with renal failure, simply because it has got logistic advantages. Say, for example, it acts on proximal tubules. So sodium absorption in proximal tubule is reduced. So there is more sodium coming in distal tubules in loop of Henle, where the loop diuretics can, it potentiates the action of loop diuretics. So it makes a lot of sense in using it, but it should be used in a proper group of patients. And then your second question was about what precautions we take in patients who have got heart failure with renal dysfunction, right?
Right.
I think patients with heart failure, particularly heart failure with reduced ejection fraction, um, they're fairly vulnerable to acute kidney injury. And I think if you want to talk about two organs in our body who talk extremely closely to each other, they're heart and kidney. No two organs talk to each other like heart and kidney. One effect on one organ immediately is reflected in the other, particularly when you're treating heart failure. So certain important things which one must remember is, particularly in treating heart failure, acute or maybe chronic, is, blood pressure stabilization, optimal volume status as much as you can maintain. There was a discussion about assessment of volume, and I would like to make a couple of comments. The most important and the most valuable uh, way of assessing real-time intravascular volume is good assessment of jugular venous pressure, which most people have probably forgotten how to, particularly the junior doctors, they don't do it. But I think it's the most important way of dealing with it, assessing it along with IVC on ultrasound. And if you add NT-proBNP to this, I think in almost all patients, you will be able to assess the volume status fairly accurately if you combine these three. So this was my comment on that. Then third thing about this, about Purva's question, is minimizing, injury to the kidney in this situation. Minimize contrast injury. Think 10 times before giving contrast to any patient who is in heart failure. You may be thinking of doing a CT, or you may be thinking of doing a coronary angiography. Avoiding nephrotoxins, as you know, it's very important. Avoiding non-steroidal anti-inflammatory drugs or nephrotoxic antibiotics, extremely important. And another important thing is, which I would like to mention here, is, people are extremely worried about starting ACE inhibitors or RAS inhibitors in people who have got heart failure and impaired renal function. And I think this particular apprehension is often misplaced. Um, if you really look at the clinical trials, in all heart failure patients, may it be SGLT2 inhibitors, and RAS inhibitors like sacubitril valsartan combination, or ACE inhibitors, or even MRAs, the cutoff for starting or not giving the drug is GFR of 60. But in many trials now, patients with eGFR of 20 or 30 have been included and found to be fairly safe in initiating these drugs in heart failure patients. The only thing that must be remembered is, you look at the creatinine, how much it jumps. If it jumps by more than 30%, or if there is a problem with potassium, these are the two things which you have to monitor. But just slight increase in creatinine is not an indication to stop the drug. Don't be apprehensive about it. It is very important that when you are trying to save the kidney, you have to also save the heart. So I need not tell this group of patients that most of the patients with kidney failure die of cardiac causes. So make sure that all these patients receive proper doses of heart failure medicine, regardless of their kidney function. Make sure that you don't start these drugs in eGFR of less than 20. But if it is more than 20, be cautious, be judicious, but use these drugs and try to stabilize the patient on these drugs. Don't be afraid of these drugs. You are putting some nephrons to sleep. You are not killing the nephrons by using these. That's what I would like to briefly say.
Right.
I mean,
Sorry,
did I
sir.
answer your question, or your question was something different, because it's a very broad question?
Yes, you're absolutely right. Actually, there is a lot of fear mongering with the fact of starting ARNIs or even starting ACRBs in patients who have AKI. But there is an ironic paradox which says that in case a patient has recently suffered an AKI, ARBs are supposed to be uh, used with caution, at least in the first 6 weeks. Um, I would like Chakravarti sir's
Just
views
one
on
comment here.
this
Just one
point.
comment. Patient with AKI, is a different animal. I mean, if somebody has somebody has landed in acute renal failure because for any reason, and if you want to treat his heart failure, I'm not saying you put this patient on RAS inhibitors or ACE inhibitors quickly. For such patients, you have to wait, let the kidney get some time to improve its function, involve a nephrologist, obviously, and try to find the cause for his kidney dysfunction, maybe infection or some contrast or some antibiotic, non-steroidals, or just hemodynamics of heart failure can produce this. So I'm not saying you start these drugs in patients with AKI. I'm trying to say that you're dealing with a patient with heart failure with chronic kidney dysfunction, and in this situation, you always have an option of using all the drugs for heart failure very cautiously.
Right, right.
I
Chakravarti
think
sir, your comments.
what Dr. Ajit was trying to say, the concept is now known as permissive AKI. You have a cohort of patients in whom there is some form of a pre-renal insult, and cardiac failure is a pre-renal insult. There is a very high amounts of angiotensin 2 which is causing the efferent arteriolar constriction. As the efferent arterial constriction increases, that means as the severity of heart failure increases, more and more angiotensin 2 is there and efferent arterial constriction is there. The intraglomerular pressure, which is raised at the cost of a high angiotensin 2, is maintaining the GFR. So when you use a RAS inhibitor in this group of people, the intraglomerular pressure drops as a result of efferent artery dilatation and the GFR drops a little, which is seen as the creatinine increase. So, in fact, the irony is those people who have a bump up in creatinine when you use a RAS inhibitor are the ones who are telling you we need it to be on board and we will do well with a RAS inhibitor on board in the long term. He also mentioned about a rise in creatinine beyond a point. Most of us accept a 30% increase, but we also look at the electrolytes. So, in short, if there is a heart failure, ACE inhibitors can be used. You follow up the electrolytes and the renal function. Below 30% rise in creatinine, we don't want to withdraw this RAS blockade. We label this group as permissive AKI, and that is what you expect when you use a RAS inhibitor in a person who is maintaining his GFR at the cost of a high angiotensin 2. So I think all of us are now comfortable using these methods. If you have access to biomarkers, maybe what you should look at is the creatinine has gone up here, but the biomarker has not gone up, which means there is no tissue damage. It is more like a hemodynamic AKI, which is good for the patient.
Yeah.
Right. So beautifully explained by both cardiologists and nephrologists. And now we are transitioning from the ICU to probably a more stable setup. And for that, I'd like to ask Dr. Samvedam sir, because he'll be transitioning the case from ICU to the ward or the OPD. How does your approach transition from initial stabilization to long-term cardiac and renal organ protection?
Thank
Samvedam sir.
you. Yeah. Thank you for this question. Here, I would like to put forward the concept of hydrodynamics. It's not hydration, it is not hemodynamics, it is hydrodynamics. How you manage your hydro will have will have an influence of how you manage your dynamics. If you overdo your hydration therapy, if you overdo your fluid therapy, your hemodynamics will never get better. That is my perspective. So when I look at a cardiorenal syndrome consult in the ICU, I would like to look at, is this patient volume overloaded? Is this patient having an RV dysfunction? And is this patient having a venous congestion? These are the three answers I would seek when I am looking at these patients. And also remember that every organ system in the body thrives on a perfusion pressure. It is not the exclusive privilege of the brain to have a perfusion pressure. There is a coronary perfusion pressure, which is a correlation between the diastolic blood pressure and the central venous pressure. You have an abdominal perfusion pressure, which is a measure of the intra-abdominal pressure and the central venous pressure. So are the perfusion pressures enough to tide over the crisis, or am I supposed to augment one of offload or augment is what I so when I want to increase the perfusion pressure, it's not always that I go up on the other side, like or the CVP or the mean arterial pressure. I might as well have to decongest the other side, like reduce the intra-abdominal pressure. How I do it with diuresis, with CRRT, with whatever decision I take, that also will be a part of my decision making process.
Right. So, my nenext question is to Chakravarti sir. Uh, Obviously, congestion will cause dilutional hypocreatinemia in fluid overloaded patients with cardiorenal syndrome. Do you feel classical creatinine thresholds for initiating RRT or ultrafiltration are outdated, and what alternative triggers do you rely on?
I believe the one cohort of patients where you will not look at the classical levels of urea creatinine for initiating RRT is heart failure patients. The most important thing here would be, again, I would like to explain the demand capacity paradigm. What we popularized in the ADKI in Hyderabad many years ago, 2016 or so. You look at your patient, he has heart failure or she has heart failure. You look at how much is the urine output. You see what is likely to be the demand on that particular kidney for the next 24 hours or 48 hours. In the background, you are supposed to see what is the cumulative balance so far, and then which organ is congested. Just like Dr. Srinivas mentioned, there is a congestive renal failure, there is a congestive liver failure, there is a every organ now we know the perfusion pressure changes as the intravenous pressure increases. Simple, in the kidney, you have a normal filtration pressure which is between the afferent arteriole and the efferent arteriole, the pressure difference. The intratubular pressure, which goes up whenever the venous pressure goes up, drops your GFR. And if you have a fluid overloaded patient in the ICU, you don't need any other reason to cause a new onset AKI. So to answer it in very simple way, heart failure patients is one cohort of patients you will not look at urea and creatinine thresholds to initiate RRT. You will look at volume status, and you will also consider whether this person's demand capacity paradigm is telling you next 24, 48 or 72 hours patient is going to do well or is going to go on ventilator. So I would rely on cumulative fluid balance. I would rely on the congestion in various organs, including the kidney, the renal function worsening, meaning that if you don't decongest this patient is going to get on to longer uh, dialysis, and there is data to support just a volume overload. The renal recovery also is much delayed, apart from, of course, the mortality. So I would encourage all of us to look at cumulative balance, and every day when you visit the patient in the ICU, look for a demand capacity paradigm, which is very simple. You look at the solute load and you look at the excretion, you look at the solvent load and you look at the excretion, and then take a call.
Right. So, with that, I will come to the next question to Ajit Bhagwat sir. We are also joined by a lot of physicians, and
You have some questions on the YouTube, Purva.
yeah. So after this, I shall be. So this question is almost very basic, but I think it is the most pivotal in preventing cardiorenal syndromes. So I'd like your any specific, apart from the textbook recommendations, would you give to the physicians in the recommendations you would give to physicians in the periphery or resource limited settings, managing acute myocardial infarction to prevent subsequent cardiorenal syndromes?
To manage acute MI to prevent subsequent kidney injury, right?
And
Yes, sir.
heart failure.
Yes.
Yeah, I mean, if you manage acute myocardial infarction according to the standard protocol and guidelines, you would probably prevent acute renal syndrome as a byproduct.
Right.
Simply because uh, if you let the myocardium die, eventually kidneys are going to suffer. Because it's ultimately, as I said, cardio-renal crosstalk is constantly going on. So treat acute myocardial infarction as an emergency, either by thrombolytic therapy or primary angioplasty. Try to preserve the myocardium as much as possible, so that the cardiac output, stroke volume, and therefore the renal blood flow and GFR is maintained, and it prevents acute kidney injury. Maintain blood pressure. In case it drops, try to maintain the blood pressure by using proper drugs like pressors. Maintain volume status. That is very important for a person working in a peripheral hospital. I have seen patients being labeled as cardiogenic shock only because patient had hypotension. So patient has an inferior volume blood pressure of 90 by 60 is labeled as a case of cardiogenic shock, and patient relatives are given all the bad prognostic indicators. They are explained that the patient is in bad situation. I think this is something which needs to be understood properly. Even in patients with acute myocardial infarction, if they develop hypotension, uh, in 8 out of 10 times, patients would do better by giving a fluid bolus rather than, giving pressors, because those patients are, they have sweated profusely and they need a lot of filling pressure to maintain good cardiac output. So maintain volume status, maintain blood pressure. Don't give any drugs which are nephrotoxic, unless they are absolutely indicated. And those are, of course, non-steroidal nephrotoxic antibiotics and contrast, IV contrast. Um, Other than these few things, uh, there are no other specific things which one has to do to prevent kidney damage. If in spite of doing it, patient develops acute kidney injury, that's not it is not the responsibility of the treating physician or a cardiologist. But you have to be particularly cautious in diabetics, long-standing diabetes who already have compromised renal function. So these are the few things which I would like to mention. If you treat acute MI properly, you will end up preserving kidneys also.
Thank you,
Right.
sir. Thank you so much. So with this, Purva, can I move on to the questions from YouTube?
Yes, sir.
So the
Sir,
first
yes.
question is from Dr. Sudhir Kulkarni, sir. I think Dr. Chakravarti, sir, should answer this question. What is the role of tolvaptan and hydralazine in diuretic resistance? So if you have a diuretic resistance, would you recommend to use tolvaptan and hydralazine?
I am not prepared for that question, but let me look at tolvaptan in heart failure itself is not a very well accepted drug. You may be able to get rid of some extra water, but you are not losing any sodium. My understanding, once you talk of heart failure, you want to get rid of sodium. The biggest problem is if you are not restricting sodium, you will have a diuretic resistance. So please make sure that your patient's sodium intake is under control. Otherwise, any diuretic that you use will definitely have a very short uh, life or short run, and after that you will not be able to get any good result. Hydralazine, I would leave it to the cardiologist to talk of. All of us do use hydralazine. I am not sure if the person who asked meant hydralazine or hydrochlorothiazide, but hydralazine is used in heart failure by the cardiologist and they can answer. Tolvaptan can be a good drug in a particular person in whom you have restricted salt, you are using a diuretic, but you feel that free water needs to be excreted, and in that subset we can use, I think there is some data, it's called salt and salt water, two different studies wherein there was tolvaptan use but I'm not able to remember the details of those studies. I would encourage you to go through. Please
Yes.
note that tolvaptan can cause liver injury, and some of these heart failure patients already have liver compromise because of a congestive hepatopathy.
I would like to make a comment here. Um, Hydralazine per se alone has no role in heart failure. Hydralazine in combination with isosorbide dinitrate is the accepted combination in treat patients with heart failure with who have CKD, chronic kidney disease. Because this combination of two drugs has been found not only to improve hemodynamics, but it also imparts survival benefit if it is used on a long-term basis. Fortunately, we have better drugs now, so this has fallen into background, so nobody uses it anymore. But still, we continue to use it. It is available as isolazine. It's a combination of isosorbide dinitrate with hydralazine, and it is used in patients who have got heart failure and chronic kidney disease because it is kidney neutral. It doesn't harm kidneys. Um, and one must know this fact that it is one of the very important drugs in treatment of heart failure in African American patients. It is probably one of the top two drugs because they have a gene in their body which kind of supports and facilitates the action of this combination. So in African American males in United States, hydralazine isosorbide combination is very, very commonly used. So this is one. And secondly, the question was about uh, tolvaptan. Tolvaptan, improvement in sodium by tolvaptan is cosmetic. It doesn't address the basic pathophysiology. Hyponatremia in heart failure is a very bad prognostic sign. If you have sodium of 115, it's the patient is doomed basically. It's extremely difficult to treat these patients. Their prognosis is bad, and the only thing you can do to these patients is restrict their water. Water restriction is the treatment. Giving tolvaptan to these patients will cosmetically increase sodium, but it will not change the prognosis.
Right, sir. Point well taken. And this next question is from Deepu. Recently, we had a guidelines on PRACI, pregnancy-related acute kidney injury, and we have a question on utility of Vexus in a pregnant woman or immediate postpartum period. So I guess Dr. Samvedam sir to answer this question.
One answer, no role. But the thing is, it also depends on what trimester of pregnancy you are looking at. But I believe the question is targeted at mid-second trimester onwards, right? So when the uterus starts becoming an abdominal organ, it no longer remains a pelvic organ. Vexus does not reflect the volume status of the patient.
So with this, I think we have come to a conclusion, and this was like a dream webinar for all of us, all starwards in one frame, and listening to everyone there our insights of cardiorenal syndromes. I guess we will plan part 2 of cardiorenal syndrome when we can discuss some more trials, some more insights, and some more concepts. With this, I think Purva, can we conclude this session?
Yeah. Just before we wrap up, because we are in the era of artificial intelligence, I'd like a quick comment on the role of artificial intelligence in cardiorenal syndrome. I've heard a few lectures by Ajit Bhagwat sir in my city, but I'd like comments from everyone. But to begin with, I'll ask Ajit sir to please share a few comments about this role in CRS.
Artificial intelligence is now intruding into every aspect of medicine. And, it's different from automation. Automation is one thing, artificial intelligence is quite another. So basically, in cardiology, we are using artificial intelligence in imaging. The previously we used to look at the image and interpret the image ourselves and try to find out what's going on. But now with AI, the image and the computer itself tells you what it is. Where is the calcium? Where is the coronary calcium? What is the thickness of the calcium? Is the calcium adventitious or intimal? And based on AI inputs, the treatment is rapidly advancing, and it can tell you what exactly which tools to be used in a given situation. So I think every faculty has experienced this, particularly the faculties which utilize imaging in management of patients. So that is one important area, and the second important area is using of AI in day-to-day practice. Sometimes you're faced with a situation which you are not familiar with. For example, if a hematologist has to treat hyponatremia, he can take the help of his colleague, but he can always take help of Chat GPT or for example, other like Grok. These are the different the AI machines, and you can take help of these AI tools to treat your patient. The only thing is you have to be cautious. Don't take every word at face value. Discuss with your colleagues and do it. But I think AI is making a huge impact on our practice.
Right, sir. Thank you so much. Thank you so much.
Your comments, I think. Rahul Pandit, sir, your comments on.
Purva, it's a very interesting thing. So but you look, AI will be a part of everything as we go forward. So it is going to be the most important thing, I think, which will help us in medicine is the predictive AI. How much, with what accuracy of sensitivity and specificity can a AI predict a problem? In this case, which we are talking about is a cardiorenal syndrome. And then once we have a prediction of that, we may be able to actually prevent it, because it's almost a waste of time if we start using AI after we have a problem. I think in every aspect of medicine, the preventive AI is going to be the most important aspect. Yes, once we have a problem, once we have a patient with us, diagnostic AI, treatment facilitation AI, those different kinds of tools will of course be used. I'm not denying that. But really, if we can prognosticate it before, sorry, we can predict it before we actually have a problem, I think that kind of AI would really be helpful. And I don't see that too far away. Honestly, if we are doing this webinar in 2030, you would actually be talking about prognosticating it and predicting it much earlier than you have a problem in your hand. So it's going to be a matter of 4 or 5 years that we'll have this.
Right. So closing remarks of this question by Samvedam, sir, because I think
We are
that
running,
time is,
we are running out of time, Purva.
yes.
I have a conflict of interest because I have now started the artificial intelligence for critical care specialist course by the ISCCM. We just started the course.
Perfect. Perfect.
And I'm a certified specialist in artificial intelligence, so I have a conflict of interest. But I must say that when you're talking about personalized prescriptions for a complex scenario which involves two complex syndromes like acute kidney injury and heart failure, and there are multiple permutations and combinations. There are lots of data to be integrated, like biomarkers, like treatment charts, ultrasound, so many numbers. I think an AI algorithm will help you guide not to make mistakes in your prescription for your patients. And that is going to be the future of personalized and humanized medicine.
Thank you, sir. That's a great comment.
We'll get in touch with you for that, sir. Thank you so much.
With that, we should conclude today's session. It was a wonderful time. Thank you so much. Good night and take care. Thank you. Thank you, sir.
Thank you very much. Bye-bye. Thank you, everyone.
Thank you, sir.
Bye.